and gentlemen, dear colleagues, good afternoon and a warm welcome to this talk from Switzerland. This talk is going to be on my catch on the future of pathology and a fully digital and interdisciplinary approach. So unfortunately, I can't be with you in person, which is really a pity, so I can't see you. I don't really know who I'm talking to, but I hope you find this thoughts I'm going to present interesting and potentially helpful also for your future tasks in doing pathology. Well, most people, when they hear pathology, think about something like that. They think about death. They don't think about living patients. And of course, we as pathologists know that this is not true. We provide diagnostic aid and decision support, and therapeutic decision support, mainly, of course, for living people. But what actually is happening inside a department of pathology, many people don't know, and even many clinicians do not know. It's like a black box. You enter some tissue and you get a diagnostic report, but what happens in between, no one knows. This has a lot to do with trust. So you need to trust your pathologist to know that he can provide the diagnosis he's certain with and he feels comfortable with. This might be easy by some, for example, a colorectal cancer, or might be more difficult in a very rare neoplasm that not many pathologists have the required experience with. When you think of a patient that just received a diagnosis, you usually think about the therapeutic options. For example, surgery, chemotherapy, radiotherapy, or psychologic aid. You think about perhaps getting a second opinion for the treatment options. But you always have to keep in mind one thing. But assessing imaging or histopathology is not like measuring exact parameters. It's not like measuring the temperature of a patient or a certain blood parameter. This has a lot to do with an interpretation of what you see under the microscope or, for example, on a CT scan. And this can contain different shades of gray, quite a lot of them actually. In pathology, the diagnosis has traditionally been based on morphology. So we look under the microscope and using pattern recognition, using certain criteria of nuclear atypia, of growth patterns, of matrix formation, all of this together with the clinical context leads to an interpretation that should yield a reliable diagnosis. And then we classify disease. We're looking for the right drawer of the disease to guide the clinician for the right treatment. We're looking for aggressiveness of the prognosis. How aggressive is a disease? How aggressively does it need to be treated? Is a resection probably enough, or has to be a neoadjuvant treatment be applied? Pattern recognition can be quite tricky. That's why pathologists, when they are more experienced, are usually better, which is usually the case with many clinical disciplines, than a beginner. And perhaps if you look under the microscope, it looks like that. And if I am looking under the microscope, hopefully, and I'm not colorblind, it appears something like that. So I see something in a pattern that you probably won't. That's, well, what pathologists do. And we have mainly two goals. On the one hand, we want to reach the correct diagnosis, still mainly based on morphology. But recently, more and more important, we also try to identify therapeutic targets. So it's not only about morphology, it's not only about diagnosis, it's also about identifying the targets for individualized treatment approaches that the oncologists today use. So a lot of things are going on in pathology. The field is changing rapidly, dynamically, and I want to focus your interest on three main points. Digitization on the one hand, an integrative interdisciplinary diagnostics, and when there's some time left, also molecular pathology. Let's start with digitization. So currently, everything we're doing is based on an assessment by naked eye. What we do is we count mitosis, which can be quite a cumbersome matter to do. We grade tumors. This is quite a subjective matter. Is it a highly differentiated tumor resembling the normal structures, or is it a poorly differentiated tumor? And what is in between? What is intermediate grade tumor? We are searching for key witnesses. That means that if we find a particular cellular alteration, then we are very sure that this guides us to a certain diagnosis. And we're looking for single cell changes. So only, for example, in neuroendocrine tumors, counting mitosis can be a task where you look like for 10 or 15 minutes under the microscope for a single slide. So it's quite time consuming and difficult to teach and to train. And still, in the end, although we can perhaps in 90-95% of cases can provide a certain and reliable diagnosis, the remaining 5 to 10% can be more difficult. And sometimes it's a little bit more evidence or eminence than evidence-based, meaning if you don't know what it is, you can send it out to an expert. You can send a consultation case. If you send it to 5 experts, you probably get 3 or 4 opinions back. So who do you trust? Well, this is what I mean with eminence-based. So now, with the digitalization of pathology, we get a new friend here. It's a digital Argus, if you want to put it that way, and in that way we hope that morphology will get more objective. I don't really think that in the short time to come the pathologist is not needed anymore because the AI system takes over. But it can help to objectify things, and it can help us to make the right call. So it's more like an assistance than a replacement. Just take this for example. This is the histologic slide. It's scanned, it's digitized from a patient with breast cancer. And you can't see the carcinomatous cells so well because this tissue is obviously heavily inflamed. So to demarcate the carcinoma infiltrates, you can use immunohistochemistry, as shown here. This is a stain against cytokeratins, and you can see now clearly the carcinomatous infiltrates. But you can also use immunohistochemistry to investigate the environment and the inflammatory cells surrounding the infiltrates. As shown here, this is a immunoreaction against CD3, which is a pan-T cell marker, and this against CD8, which demarcates the T killer cells. Another marker that is very difficult to evaluate actually is PD-L1, which obviously guides immunotherapy, or is at least used to predict a response for immunotherapy. So now if you need to evaluate this marker, and perhaps you need a certain cutoff to include your patient into a study or not, an algorithm-based evaluation of these markers to objectify it would be very helpful. This could look like that. I'm going to show you an easier example because PD-L1 is a particularly difficult stain to evaluate, but for example, take this cytokeratin stain again, you mark your area of interest, and then you let the algorithm do the work, and it counts you every single cell and tells you that in this area there are 922 positive cells, there are 1,350 negative cells, and the positivity is around 40%. So this is completely useless, it's just an example, but if you could do this as PD-L1 or other predictive markers, take for example ER, PR in breast cancer, Ki67, HER2, that would be extremely helpful, and this will become a very important thing in the future. So what you need to do that, you need a slide scanner, We have one from Roche, the DP200. We also have the DP600 currently as a test machine to evaluate, which is able to scan much more slides than only this tray of 6. But the problem is, and which is much different to radiology, is that we cannot provide, or that we cannot perform digital images, digital slides, without actually cutting tissue. So we still have to run the complete normal workflow. So we have to embed the tissue, we have to make paraffin blocks, we have to cut the sections. And if we have the specimens ready to go under the microscope, then we need to digitize them separately. And this is another step that adds another layer of complexity. And it's also something that, of course, is error prone. Not everything that you scan is on focus. Sometimes not the whole tissue is scanned, things like that. And all these slides, because they need such a high resolution, take a lot of storage space. So one slide usually is about 1 to 2.5 gigabytes of data. So just keep that in mind. What are opportunities for digital transformation? Well, it simplifies slide reproduction and sharing. You don't have to send your glass slides around the globe, which is currently still done. You can just send them over via a link or via whatever you can provide digitally. There are different solutions, and then everybody in the world can look at those slides and diagnose or help you diagnosing them. It, of course, increases the efficiency of archive slide retrieval. So we still have a lot of glass slide archives. So if we need to look at a slide from 5 years ago, then somebody has to go to the cell and search it. That is no longer necessary if you have a digital archive. It facilitates remote pathology, working from home, and consultation. It enhances education and research, displays multiple stains simultaneously, which you now have to compare one by one. And of course, it enables computational pathology and research opportunities that you cannot use if you're not digitized in the first place. So the problem is that a lot of the things that are cool and that are great in digital pathology can only be tested if you already underwent digital transformation. That is a downside. And of course, it permits electronic interface with other data. So it's very important for the integrative diagnostics I will come back to a little later. So this is how it looks like in Basel currently still. So we're about to digitize probably in the next, 1 or 2 years. So it's already started. We get the first new batch of scanners in 2 or 3 months, but this is a long process. This has to be carefully planned, meticulously planned, because it really changes the whole workflow. But this hopefully will become something for the for our archives, but no longer in the form of a digital. What are the challenges? Well, you have significant upfront costs, obviously, for the scanners, for the infrastructure, for the storage space. And they keep going on. So it's not a one-time investment. You have a maintenance cost. You need major infrastructure modifications, and you still keep the glass slides. Well, why do we do that? Because glass slides do not contain only optical information. They also contain tissue, which you could use for extracting DNA, for example, or adding additional immunostains. So we're currently keeping it. We're also keeping the paraffin blocks, so we could do new sections, but these are the sections that we made the diagnosis on. So currently we still plan to keep them, but this will change obviously in the future. And well, if you really want to use those data or these systems to enhance efficiency, as I said before, you need to implement the digital pathology in the first place. And that is a little bit difficult to convince people, because they say, well, we are perfectly fine with our microscope. We don't need those new tools, and you can't showcase them without having a digital infrastructure. As mentioned as well, so we plan about 1.5 or even until 3.5 gigabits per level and slide. So sometimes you even need more levels per slide, so then it increases especially accordingly. Here in Basel, we have roughly about 1,000 to 1,400 slides per day, so roughly up to 400,000 slides per year. And this would mean that if we go fully digital, would require 6 to 8 times more storage than required for our radiology department. And of course, if we would decide to also do a retrospective scanning of the archives, then we would have more than 3 million slides, and you can make the math that this would require quite a lot of data storage capacity. It's complex to undergo a digital transformation. This is one of the overviews that we built for our digitization. So as you can see, there are central parts done in the hospital that are connected not only to our laboratory information system, but also to the radiology information system, because actually we are about to use a system where the imaging of the radiology and the histology is stored in the same place. But we also have decentralized areas, so where we can work from home. And we have other clinics that are roughly about 30, 40, 50 kilometers away from here, for which we provide fresh frozen tissue analysis via digital pathology. Currently, we're about to build a Swiss digital pathology initiative where all 5 university hospitals get connected using the same infrastructure in terms of data storage, in terms of exchanging file formats and scanners. So we can easily, also for scientific purposes, increase our numbers of, for example, certain tumors and work nicely together. That is something that is enabled by digitization in a different way than it was before. So I think currently it's very important to set the course, put things on the right track, and to undergo digital transformation. I hope I could at least convince you a little bit. I think you just need to try. You have to look, perhaps make a visit to departments that have already undergone digitization. And that, at least my experience is, anyone I talked to who underwent digital transformation already never wanted to go back. So I think that is quite convincing. What is equally convincing, for me at least, is integrative diagnostics. So we're very proud as pathologists that we can work with our microscope. But we are increasingly aware that we can't and that we shouldn't do that in isolation. Take this for example. So these are 9 different tumors. There are 9 different bone tumors because I'm a bone tumor pathologist. On the left side, on the left upper side, it's a completely benign lesion that wouldn't have needed biopsy in the first place. On the right lower picture, you can see a highly malignant tumor that will probably kill the patients in a few months. So I hope you agree that those 9 pictures, at least vaguely, look similar because they all contain giant cells, and even for a pathologist, they are quite similar. So it's a little bit like this. Things that can appear scary can be benign, and things that can appear benign are scary, or at least malignant. It's a bit like this. So my father-in-law, he's an ornithologist. And when I show him this feather and I ask him, well, you're an ornithologist, please tell me what bird it is from. He will say, well, I can confirm it's a feather, but it's a white feather. So there are many birds who have white feathers. On the other hand, if I show him this feather, I don't even need to ask him. And it's a little bit like this, right? So there are some things that are just similar and they're difficult to interpret without the proper context. If you now compare those 9 images with the radiologic features of those tumors, then you can see there are major differences. And if you interpret everything together, then you get to the correct diagnosis. That's why I think the current situation where everybody is doing or mostly working on its own is not timely anymore. And that's why we in Basel came up with the idea of a so-called comprehensive digital diagnostic department where all the diagnostic players work together, and we started showcasing this, combining radiology and pathology as an integrative diagnostics. And that's how it's supposed to look like. So we have everything on the same platform. We open up the results we have from a patient. We see the imaging, we see the histopathology, we can discuss together, and ideally, prospectively, as a vision, for me at least, I would like to see it happening that radiologists and pathologists sign a report together. That would be an ideal situation. So in pathology, we're usually doing tissue diagnostics or liquid diagnostics. We can investigate those by morphology or molecularly. We can provide the additional tests based on morphology or based on nucleic acids or methylome and proteome. And we know that the morphology is not digitized so far in most of the places. As I showed you, there are so many slides archived there. There's so much potential to use. And the digital or the molecular pathology is increasingly digitized. So what happens with all those data? So only the data that is acquired and interpreted in the pathology department will be interpreted by a single pathologist or by a group of pathologists and result in an epicritic pathology report. Mostly it's not structured, but it could be. But we all know that this is only a very tiny part of the patient. Actually, or literally, it's a tiny part. It's usually a biopsy. But there's so many other things that are known from the patient and that are acquired during a hospital stay that we're not aware of. But in the end, someone has to put everything together. And discrepancies get apparent only at the MDT meeting, if at all, because most of the things are not discussed. So what I'm saying is we're acquiring more and more data that is still interpreted manually. And this leads to mistakes and should be changed in the future, especially as we are continuously producing more and more. Our approach in Basel would be to put all the information that is obtained during a hospital stay into a digital diagnostic platform via the so-called digital data warehouse. And everything that belongs to this patient should be taken into account to make an integrative interpretation. And this could be, of course, guided and supported by utilizing AI, machine learning, algorithms for image data analysis, for a so-called, if you want to put it that way, a diagnostic decision support, and of course also in the end to identify molecular targets, which, as I outlined before, called the Comprehensive Digital Diagnostic Department. Well, how will this look like in the future? So this is a paper from 2016, and it's an interesting aspect, because in this paper the authors already propose that radiologists and pathologists should fuse together to one specialty, which they called the information specialists. And I think this is really an interesting thought. I don't know if we really need to change the specialties, but working together more closely is, I think, very important. It's also looking beyond the usual comfort zone that you're currently in, that you're experienced in, accept new challenges. That one doctor will be in charge of everything and can manage everything is, I think, a discontinued model. It won't work that way in the future. And I'm going to give you some few examples out of my diagnostic service that I find quite illustrating in this regard. This is from a recent case of a 65-year-old male, and I got the following tissue. This is how it looked like. It's cartilage tissue, and it came back it was from the spine, and the pathologist asked me if this could be a chondrosarcoma. It's another picture, and to me this is not a chondrosarcoma. This is just regular cartilage tissue of an intervertebral disc. So I called the neurosurgeons in the other clinic, which the pathologist who sent me the case should have done in the first place, and he said, I don't know what they're talking about. It's just an intervertebral disc. So before they discuss the thing in the same clinic, they're sending a consultation case to a different country to ask me if this is a cartilage tumor. Perhaps it sounds familiar to you. Another case, a little bit more severe, from a 12-year-old boy. So he had pain on his right humerus. Radiologically, it was called suspicious of a malignant bone tumor. Then they made a biopsy, looked like that. This is new bone formation. And of course, new bone formation can happen also in bone-forming tumors, like in osteosarcoma. But this is not an osteosarcoma because it does not have any atypical cells. It's just a reactive new bone formation, as shown here as well. It's just a callus formation that was caused by a stress fracture. So the pathologist in this clinic said it's an osteosarcoma. So this was the diagnosis, high-grade osteosarcoma. They started treating the boy with a neo-RT1 chemotherapy, and then they decided to send the case out for consultation as a confirmation, and it was discontinued after reference pathology. So it's important to remain wide-sided, to see the context and to see your limitations. If you're not experienced in a certain area of expertise, then you probably should rather ask an expert and before you start the treatment. Are these exceptional cases? In the Bone Tumor Reference Center, which I'm heading in Basel, we made an analysis once about the first 13,000 cases. We had to change the initial diagnosis in roughly 50% of cases, but of course, changing diagnosis does not necessarily mean that it's clinically relevant. But we needed to change from benign to malignant in roughly 9%, and from malignant to benign in 500 cases. So almost 9% as well. Always keep in mind, we never know who has been overtreated, but we will learn who has been undertreated. That's why I think to reach a reliable diagnosis, not only the two, radiology and pathology, need to be put together, but everything that adds to the diagnostic is important. So you as a clinician need to make sure that you give your pathologist, your radiologist, your diagnostic expert all the information that he needs to provide a proper diagnosis. A lot of things are misunderstandings, so communication is vital in this. And of course, everybody involved in the care of patients is only a piece of the puzzle that needs to be put together. So I think there's a lot of change going on currently, which provides a lot of chances also. With the diagnostic disciplines coming closer together, I think the diagnostic quality will improve significantly and provide the basis for an excellent care by the clinicians. So as a pathologist working in the current times, I think it's important to know when to hop on the train and not to be too late. Planning a digital transformation is a thing that takes time. It's nothing you can do within a half a year. You usually need 2 or 3 years of planning. You need the money, you need a lot of people to support you and to guide you through this process. But I think it's really worth doing it. So I think I reached the end of my speaking time already. So I didn't mention the molecular changes that are going on currently, and I'm happy to do that at another time. By now, I hope that you found this lecture interesting and stimulating. And I'm very happy to answer questions, also if you prefer by email. Thank you very much for your attention, and thank you again for having me. Best wishes from Switzerland.